go ahead and start answering some Q&As that we have in here. Um, the first question is from Adil. How often can you do TPI or joint injection max per year?
Okay, so those are two very different questions. Joint injections. So part of it depends on what it is that you're injecting. So one thing always to consider is the physical trauma to a structure with injecting. So less of an issue with joints than it is with trigger point injections, because joints you're just passing in, coming out. The real question with joints is how frequently you can inject steroid. That information is not static. It's always changing. There's always study going on about this. I generally, for a younger patient, meaning say below around 45, I will try to limit my total injections into a certain joint to about 3 injections total, or that will be, if it's an acute joint inflammation, I'll do it as frequently as every month, but I'm going to need to know why that joint is becoming inflamed. And again, I'll try to limit it to a total of 3 in this period for a younger patient. For older patients, I try to do steroid injections into joints no more than twice a year, so every 6 months. At times, you'll need to do a repeat injection into one particular joint in order to get inflammation under control. And I'll tell patients, okay, we might do this 2 or 3 times into this particular joint, but then we need to take a break of at least 6 months before we consider doing it again. And then you can cycle through alternate therapies in the meantime. So I have seen practitioners that will do injections into one joint as frequently as every month throughout the year. It would be an extreme situation in which I would do that. I, again, try to limit it to twice a year within any particular joint. For trigger point injections, it's very different. Trigger point injections, you don't have to use steroid. You can use just local anesthetic. You can also use nothing at all. There are different methods of doing trigger point injections. I tell people that I will do trigger point injections as frequently as once a week, especially if they have a very spastic area, an area of chronic spasm. It's not a permanent treatment that we're doing it every week all year long. It's usually in more discrete periods, 3 to 6 treatments every week to help get an area under control in conjunction with oral medications and physical therapy. If I am using steroids, which I do sometimes use with trigger point injections, which we'll talk about later today, I am wary of the total dose of steroid that I'm injecting. If I'm going to be doing frequent treatments, I will either use a lower quantity of steroid at each dose, or I will use steroid at the initial dose, but then at subsequent treatments, I'll only use local anesthetic. So usually no more frequently than once a week for trigger points. The only situation which I will do more frequently is if it's someone who doesn't normally have a myofascial issue, who has a sudden area of severe spasm, a younger patient who throws out their back, for example, I may do treatments as frequently as every 3 days in order to help them get through that acute period. But those are more extreme situations. If you have any particular situations you want to ask me about, please feel free to email me and I'll give you my opinion.
The next question is from Joseph. Would you consider injection of a hemiarthroplastic joint of the knee, for example?
Hemiarthroplastic. So anytime that there is a prosthesis in a joint, anytime that there's a foreign body that's been placed by a surgeon. So think about the intricacies of a joint arthroplasty, hemiarthroplasty or total arthroplasty. There is a prosthetic joint in there, or at least a portion of a prosthetic joint. If you introduce an infection in that area, or around that area, you are potentially buying the patient a repeat surgery. I personally tend to stay away uniformly from prostheses that are in the body in my injections. As I said before, it's not impossible to inject those joints. However, if those joints are going to be injected, if at all possible, will refer the patient back to the person who originally placed the joint. If anything goes wrong with the joint in terms of infection, it's in their hands. In addition, they probably need to know that the patient is having persistent pain. I generally will communicate directly with the surgeon that I'm referring the patient back to, because sometimes there's no further treatment that the surgeon can do, in which case I can become more advanced in my treatments, and I can do things such as genicular blocks for the knee, etc. Other therapies that are not specifically within the joint, but almost uniformly. If there's a prosthetic joint or partial joint in the body, I prefer not to put a needle next to it.
Thank you, Dr. Samuelson. The next question is from Beverly Hodges.
Oh,
She said that she was told no more than 3 injections annually and no sooner than 3 months from last injection. How does this correlate with okay to repeat injections on follow-up visit?
So again, it depends on what it is that you're injecting. If it's steroid, it sounds like you're referring to steroid. It has to do with, there are always new studies coming out suggesting different varying levels of safety with particular steroids in joints. The concern is that chronic injection of steroid into a particular joint will lead to breakdown of joint structures, will actually make the pathology within that joint worse. Again, those studies are inconsistent in their results, but out of caution, out of respect for risk avoidance, I tend to try to minimize steroid injections in a joint to a cycle of 3, and then depending on the patient, depending on the joint, I will do up to 2 cycles of 3 per year. It really depends. So 6 injections is a lot in one joint for me to do in a year. I tend to stick to 3. But if you're not injecting steroid, the rules are completely different. Hyaluronic acid, for example, if you're injecting hyaluronic acid, there are preparations of hyaluronic acid that are intended to be a 5-step injection process. So 5 separate injections into one joint would be the complete hyaluronic acid treatment. So depending on the interval that you choose, anywhere from 1 to 4 weeks, you may be injecting a lot more frequently. That is one complete cycle of the hyaluronic acid. So it really depends on what it is that you're injecting, that injection frequency. Do keep in mind that especially with a joint, a closed space in the body, every time that you do inject that joint, you are reintroducing the possibility of infection into that joint or of traumatic damage from just unfortunate errors or techniques, etc. The more frequent injections that you're going to do into the same joint, you may want to consider, if you have skill with imaging, ultrasound, or fluoroscopy, using ultrasound or fluoroscopy just to decrease the risk of damage as much as possible. But if you're very comfortable with palpation and landmark-based injections, as a lot of rheumatologists are, that becomes a lot less of a factor. So it really depends on what you're injecting is the end result of that answer.
Thank you, Dr. Samuelson. The next question is from Joseph Ambrose. What are your opinions of using Celestone?
Of using Celestone steroid? Mm-hmm. So most practitioners tend to find their medications that they're comfortable with and stick with those. I do the same. It happens I don't use Celestone. I use triamcinolone, I use dexamethasone, I use methylprednisolone. That's pretty much all that I use for varying purposes. If I want a particulate steroid and I want to take advantage of the properties of a particulate steroid, I will use methylprednisolone, which you want to be careful about paying attention to your formulations. It'll say on the formulation where it is FDA approved to inject that. Doesn't mean that you can't put it other places, but FDA approval for methylprednisolone, for example, can be given IV or IM or intraarticular. That's my particulate when I want it to stay there for a few days. For semi-particulate, so if I want to get some of the properties of the steroid staying in one place for a little bit, but I don't want a particulate steroid, for example, if I'm worried about vascular uptake near the head, for example, I am more inclined to use betamethasone, which is semi-particulate, which is still quite potent. And then if I'm very concerned about vascular uptake or I want to have some more vascular uptake, I will use dexamethasone, which is completely non-particulate. So those are the ones that I'm most comfortable with. I have no problem with switching to others if need be, based on availability, et cetera. But you can pick your poison, as it were.
Thank you, Dr. Samuelson. The next question is from Beverly Hodges. Increased effect related to long-term use with steroids such as buffalo hemp, moon phase, what did you consider long-term use?
So if I heard you properly, it said side effects from long-term use of steroids?
Increased
I see it.
effect related to long-term use with steroids.
Yeah, I see it. Okay. So frankly, those are the things mostly that you'll see with oral steroid use. So patients that come in with chronic inflammatory diseases, so systemic lupus erythematosus or rheumatoid arthritis, any of these inflammatory conditions that they are seeing a rheumatologist for. If a patient sees a pulmonologist and takes chronic steroids for a lung process, like chronic daily prednisone, these are the patients that you'll see a lot of these side effects on. And so they'll get the buffalo hump, the thinning, the chronic of the skin, the chronic hyperglycemia, et cetera. For my purposes, I so infrequently give oral steroids because I'm an interventionalist. The only side effects that I tend to see more frequently, hyperglycemia, which again, I only notice if the patient is paying attention to their blood sugar because they have diabetes, occasional water retention, very occasional menstrual irregularities, and changes in mood, etc. And I'm also careful. The procedures that I do that would have the greater likelihood of exposing someone to chronic steroid use. So I have a fair number of patients who come in for regular trigger point injections. So on average, between 20 and 25 times a year for trigger point injections. If I were using a large dose of injectable steroid for each of those treatments, that would count as chronic steroid use. I would expect to see side effects of steroids for those patients. But for if you're doing on average one steroid injection per month and you're cycling through different joints, et cetera, I would not expect to see any side effects of chronic steroid use. It's really if it's constant higher level exposure with systemic absorption.
Thank you, Dr. Samuelson. The next question is coming from Maurice Roberts. Do you recommend Hyalgan injections in knee joints for OA?
Osteoarthritis, absolutely, I do. So does the FDA, so does Medicare. So hyaluronic acid preparations, and there are quite a few. It doesn't have to be Hyalgan. They vary in their origin, whether it's a rooster comb or not. They vary in terms of their design for injection. There are certain preparations that are injected a single time, like Synvisc 1, for example. You only have to access the joint once. You put in your inject date, you're good to go. For other preparations, it's 3 to 5 injections. You need to be specific as far as the inject date that you're using. And we'll mention this later, but that becomes more of an issue with insurance coverage. A lot of insurances are specific about the hyaluronic acid preparations that they will cover. If you're not an insurance accepting provider and the patient is paying out of pocket, then I tend to, for most patients, lean more towards suggesting the lower number of injection preparations like Synvisc 1, for example, because most patients welcome the idea of only having to undergo that injection once. Hyaluronic acid injections, the general thinking is you can do those up to twice a year. And as I showed on the slide earlier, if you're going the route of hyaluronic acid, repeating that injection or in that injection cycle every 6 months for a period of 3 to 5 cycles tends to have a cumulative effect in terms of overall pain relief within that joint. And there's really not a time that is too soon for hyaluronic acid. It's useful when joint damage is only moderate in terms of helping to prevent further damage or to delay further damage. And what I and a lot of practitioners will do, I will generally start with a steroid injection into a joint. That demonstrates to me and to the patient that treating that joint, specifically treating that joint, will give them some pain relief. And then I'll advance to hyaluronic acid as an alternate for steroids in order to decrease the frequency of steroid use. So, for example, I'll do a steroid injection into a joint twice a year. Alternating, I'll do hyaluronic acid injections, and I'll time those to the patient's symptoms whenever the patient's symptoms worsen.
All right, thank you, Dr. Samuelson. The next question is from Jean-Pierre Cabongo. I would like to know how often can you safely inject steroids in a joint? Any maximum limit?
So again, this information is not uniform. And if you do, if you are going to be giving intra-articular steroid injections, it behooves you to stay on top of the literature. And you can do that by attending your regular conferences or by just following the pertinent medical journals. Even if you're not a family practitioner, the American Association of Family Practice, they are a good repository for a lot of information that comes out about safety margins for orthopedic procedures, for example. Unless it's an extreme situation, I won't put steroid into a joint more frequently than every 30 days. I limit with my patients intra-articular injections to, I try to limit it to 2 injections per year, sometimes 3, or if they're running out of treatment options, I will go more frequently. I will tell you that intra-articular steroid injections, especially in older patients, do tend to lose efficacy over time. So anything that I can do to preserve the length of efficacy of those injections, such as alternating with hyaluronic acid or extending the interval between those injections, anything I can do to make them last longer is good. Younger patients, the most recent thinking with younger patients is that you try to limit it to 3 per lifetime in a particular joint. Again, I think we're going to keep learning new information about this, but with the younger patient, while I'm treating them, I try to make sure that until they are, at least in their 50s, for example, I don't inject them more than a total of 3 times in any one particular joint. Just as sort of a rough guide of the idea is that if there is potential long-term damage from steroids, and you give someone a lot of steroids when they're young, they have a lot longer time to develop that long-term damage. The older a patient is, the less you worry about those longer-term outcomes.
Thank you, Doc. Do you always get x-rays prior to injecting?
No, I don't always get imaging prior to injecting. For this, you need to be sure about, again, if you take insurance, if you take Medicare, there are steps that you have to follow for coverage in a lot of cases. You may or may not need to get imaging before you inject a joint. X-ray is cheap and easy as far as imaging. It's not hard to send someone for an X-ray. I have a low threshold for doing so. That being said, if someone has a clear clinical presentation of a joint arthropathy, and I can demonstrate and I can document that they have a clear and convincing presentation of that joint arthropathy, I will do arthrocentesis without imaging in most cases. If I do that injection and the patient doesn't get as good relief as I would expect, then I will almost uniformly get some imaging before I inject any further. And my hierarchy for imaging for bony joints, X-ray is always going to be my imaging modality of choice. If it's something that I want to do in my office, I will use ultrasound for diagnosis. But again, we can talk about that with our ultrasound lecture tomorrow. If it is a potential soft tissue injury, then I will consider CT or MRI, keeping in mind that some patients have difficulty with MRI as far as claustrophobia, et cetera. And MRI, you frequently will need, if you have insured patients, you frequently will need to get a prior authorization from their insurance company, from their insurance carrier, before you can do these more expensive imaging modalities. So the short answer is no, I don't always get imaging. However, if I feel like I need it before I can progress clinically in my algorithm, then I will get imaging.
I have a question from Stella. How do you choose between steroids and biologics for injections? What influences your choice of injecting?
Sure. So that's a good question. The first thing that's important to that question is whether you offer biologics in your practice. Stem cells and PRP, it requires you to have the capability and the knowledge to do the harvesting of the product. So you need to either have the ability to draw the blood and spin it down, or to harvest fat or bone marrow and concentrate that as well. So not all practices have that capability. You need a centrifuge, and you need skilled providers, and usually you need a second pair of hands. If you have those available, which I do in my practice, by and large, it's sort of a more advanced step in the algorithm for joints, et cetera. Although it's patient dependent. I will readily suggest PRP and stem cells for tendinous injuries, medial epicondylitis, lateral epicondylitis, laxity in the rotator cuff, partial tears, et cetera. Anything that I think could be repaired by the body. I think my internet connection's unstable. Let me know if you're hearing me clearly. I think we're okay. Anything that I think is easily repairable by the body, I will consider biologics in. So a younger patient that comes to me with lateral epicondylitis, I will generally do a steroid injection for them with local anesthetic, and I tell them it's diagnostic as well as therapeutic. I may or may not have MRI imaging of that injury, but if I've done a steroid injection, possibly more than one, and the patient got relief, but it didn't last, then I will absolutely suggest biologics to that patient. Other patients come to me specifically already thinking of biologics. They come to me because they know that I offer PRP and stem cell, and they will want that because they're more knowledgeable. They're aware of the utility of biologics in these cases, so they'll come requesting them. For intra-articular injections, I am much more careful about how I incorporate my suggestion of those therapies into my discussions with the patient. There's not as much evidence. There's plenty of anecdotal evidence, but there's not as much clear, repeated evidence of efficacy of these biologics for intra-articular injections. I'm careful what I say. I'll tell people biologics tend to slow down joint destruction in osteoarthritis, tend to arrest progression for a time of osteoarthritis. Your pain can be better controlled. We'll use other modalities to control your pain. I'm very careful about saying anything like biologics, stem cells will regrow your cartilage, simply because that won't always happen. And I, both in my observation and in published observations by other practitioners, that doesn't always happen. It can help, but I don't want to make promises that I can't keep. So if I'm going to incorporate biologics into intra-articular injections, I usually will have done corticosteroids. I usually will have cycled through hyaluronic acid, so that by the time that I am offering this patient biologics, there's the added weight of, we tried these others and they weren't working. So this is another thing that we can try. And if we've gone through all of these tiers, then it might be time for you to consider surgery. So it depends on the injury that I'm treating, and it depends on the patient how soon I'm going to offer biologics.
Fantastic, doctor. Thank you for answering that. The next question is from Charmin. For knee OA, do you find PRP works better than hyaluronic acid injection?
Knee versus hyaluronic acid. And this is PRP?
PRP, yeah. For knee OA, do you find PRP works better than hyaluronic acid for injections?
No, they have different purposes, really. Hyaluronic acid, if there's a fair amount of cartilage breakdown, and I feel like the knee could benefit from the lubricating effects of hyaluronic acid, I will utilize hyaluronic acid, and it's frequently a very useful therapy. PRP, again, it depends on the patient how soon I will incorporate it. The nice thing about hyaluronic acid is it's easily repeatable to do hyaluronic acid treatments, either multiple injections within one series or multiple series within a year. So if the first injection or two doesn't help with hyaluronic acid, which frequently it won't if it's a multi-injection protocol for that particular product, I just keep on injecting the patient, and it gives me a chance to maintain my relationship with the patient, track their benefit, et cetera, and increase the benefit with the subsequent injections. PRP, anytime there are biologics, because they are a less proven therapy, which does not mean they don't work, it means they are less proven. Anytime there's a less proven therapy, which becomes a cash therapy, it is just as much patient factors as it is factors related to that specific joint breakdown, et cetera, that are going to influence my decision to offer PRP to the patient. Some patients are very receptive to the idea of PRP, really like the idea of PRP, and they're going to maintain good expectations. And I will tell them, you know, because of the nature of this treatment, you're likely not going to get the immediate relief that you would with a steroid injection, for example. However, we're going to do this treatment. We're going to incorporate physical therapy, et cetera. You're going to see a more gradual improvement, but a longer lasting improvement. Again, it's difficult to say specific cases. Yeah, that's the short answer for that. If you want to talk about specific cases, et cetera, I'm happy to answer them by email.
Thank you, doctor. The next question is from Adil. Max per year with TPI?
No, there's not really a max per year with TPI. So trigger point injections, which we're going to talk about this afternoon, depends on what you're injecting, but I will repeat them for latent trigger points, so more chronic issues. If you're going through a flare of pain, I'll repeat them as frequently as every week for some patients. Other patients, you know, maybe twice a month. The most frequently I will do trigger point injections, especially if there's a specific muscle in spasm, like the quadratus muscle, for example. I may do every 3 days to help get them through this acute phase. But max per year, there really isn't a max per year. Maximum steroid dose that I will give per year, yeah, I've become more and more careful in the amount of steroid that I will inject, just because I don't want to expose a patient to the cumulative effects of a lot of steroids necessarily. So if I need to do frequent trigger point injections, I will just use a lower quantity of steroid or skip steroid completely in some of the injections that I give.
Thank you. Would you inject a MS PT to help with spasms?
Oh, MS patient, got you.
Yeah. Did you see that?
No, but I understand the question. Yeah. Would I inject an MS patient with what?
And a specific area such as a constant spasms in the shoulder neck area. Would you consider a botulinum toxin injection to help with the spasms for these PTS?
Yeah, absolutely. So that's a very good question. This is referring to a multiple sclerosis patient or any patient that has an underlying disease that causes spasticity. And there are patients that have, you know, syndromes or conditions that are whole body syndromes. There are also patients who have isolated conditions such as torticollis, various kinds of torticollis or spasm of the neck muscles. So as I mentioned before, Botox has a couple of indications. That's, again, it's a bit out of the scope of this lecture because we still have a fair bit to talk about. But Botox can be injected perineural, so around specific nerves, as is the goal with migraine. And it can also be injected with the goal being intramuscular to relax those muscles, which is more the case with chronic spasm. I absolutely will inject specific muscles in patients that are pathologically spastic. However, you do have to be careful because a lot of times with MS patients, for example, or any spastic patient, like a torticollis patient, for example, you need to be careful about precisely which muscles you're going to relax in the neck. There is a vendor-sponsored training available to help you do that. You may, if it's a specific enough target, want to refer those patients to a neurologist just because they're going to do EMG feedback as they inject to help them identify their target. Or if you get good with ultrasound, you may be able to identify the target visually as you're going to inject. The general rule with injecting any postural muscles, neck muscles, back muscles, et cetera, is be careful that you don't over weaken those postural muscles because you can paradoxically lead to more pain. But with torticollis, for example, spasm in the neck and shoulders, there are some very specific distortion patterns of posture that are associated with different muscles. If I am considering Botox for a patient to help a patient relax an area of chronic spasm, I almost always will have done trigger points beforehand to at least demonstrate that by injecting certain muscles with local anesthetic, I can relieve their pain. And I may or may not be able to achieve some relaxation. So Botox is never the initial treatment. but it is absolutely something that that is potential for these patients with chronic spasm. And once you do this, it becomes a repeated treatment, usually 4 times a year. If you get effective relief with Botox for specific areas of spasm, you will often do it up to 4 times a year. And the other nice thing about Botox injections for spasm, depending on the particular diagnosis code that you use, a lot of these are actually covered by insurance, specific indications for Botox, which becomes important for patients that you are considering having to purchase the medication out of pocket versus the medication being purchased by their insurance company.
All right, thank you, doctor. The next question is from Chastity. In her current practice, she was taught that dexamethasone can only be given every 3 months for shoulder or hip joint injections. Is this typical in other practices? Also, do you feel that Kenalog is less or more effective than dexamethasone for these joints?
So, a good question. Any hard and fast limits for steroids with the current levels of understanding it's hard to be able to draw a line in the sand and say, this is too much. You cannot do more than this. There are no hard and fast indications. It is all judgment of practitioner. And with dexamethasone, for perspective, in the field of anesthesia, when I've got my anesthesia hat on, we'll give dexamethasone intravenous, even if someone has 6 surgeries in 6 weeks, we give it as an antiemetic intravascular, and we'll give doses of it every time the patient goes under anesthesia. So there are no set limits for dexamethasone. However, with all steroids, we worry about cumulative effects of steroids, especially with patients that have risk factors for cumulative effects, such as poorly controlled diabetes, etc. Dexamethasone versus Kenalog. So number one, the potency of dexamethasone is much higher than of Kenalog. Earlier in the presentation, I showed you some steroid charts that show comparative potency of the different steroids. However, you also are considering at that point the preparation of the steroid. Depot formulations of steroid are designed to stay as much as possible in the area you inject them, depending on where it's injected. So they stay effectively within joints and are uptaken by the body slowly. They stay less time within specific areas of the muscle or around the neuraxis, for example. I will expect them to stay for at least 48 to 72 hours in that area. Non-particulate formulations like dexamethasone, it's very difficult to prevent them from being retaken up by the body. So you have the potency of the steroid, but then you also have its tendency to stay in the area you're treating.
All right, thank you, doctor. We're gonna go with the next question.
Okay.
If the patient complains of pain increase during the knee injection, what some incorrect structures could be affected? What could be the consequence of injecting into the wrong structure?
Sure, excellent question. So again, if you're using landmark-based injections, you absolutely need to become familiar not just with landmarks, but also with the changes in feedback you get from a needle, whether you're injecting into free potential space or within a denser structure. So if a patient is complaining of pain as you're injecting within a knee, so they may have pain as you're approaching the knee. Most of the pain with knee injections is going to happen when you are touching the bone with that needle tip. Depending on how deep you are within the joint, if you are avulsing cartilage from the knee, for example, they will likely complain of pain with that. If you are, anytime that it hurts when you're injecting, rule of thumb, stop, reassess. If it hurts when you're injecting, don't just keep forcing it in because there's probably something wrong. If you are within a joint capsule in the proper space, there's plenty of potential space and it won't hurt to inject it. If you're in a smaller joint, like in a acromioclavicular joint, for example, that's different. You can only fit so much volume in before it starts to hurt. But in general, in the knee, if it hurts while you're injecting, my tendency is to pause, reassess, how does it feel as I'm pushing the medication, and reposition my needle tip. It shouldn't hurt while you're injecting.
Fantastic. The next question is from Michael Castillo. Are you combined with homeopathic medication?
So homeopathic medication. So it happens that I'm a believer in complementary and alternative medical therapies. I am an acupuncturist, a licensed acupuncturist. I am open-minded to Ayurvedic therapies. I am extremely open-minded to, in fact, I require it in a lot of cases, mindfulness training with pain management. I have some psychologists that I will refer patients to for mindfulness training unless I feel like they're savvy enough to find it on their own. All complementary and alternative therapies, as far as I'm concerned, they will help what I'm doing. And patients, this is a very important point. For all pain, there's a nociceptive input and there's an experiential component of it, right? So if you cut your finger, there's the damage that comes that is happening to the finger, that your body's sending the pain through your various nociceptive fibers saying this hurts. There's damage happening here. Then there is your experiential component of it, which is, how do I feel about pain in general? How do I feel about my day? What's my emotional environment and my emotional season right now? So am I really stressed out? Am I completely overwhelmed? Am I at home, for weeks and weeks because of COVID? You cut your finger, it's a big deal. You're busy, you're happy, you're doing sports, etc. You cut your finger, you shake it off, right? So all these complementary therapies can help harness all those components of it that are experiential, that are more difficult to treat with a needle. And there's always a possibility with acupuncture, for example. This has been around for thousands of years. I can't, just because Western medicine, it's difficult for us to prove the effects of acupuncture, I can't discount it. So I absolutely allow for it, encourage it in certain patients, and sometimes do it myself.
Awesome. Thank you, Dr. Samuelson. We're going to have one more question so we can complete the agenda. The next question is there an age cutoff that you wouldn't inject any longer? For example, an 85-year-old with shoulder pain?
No, absolutely not. Reason being that sometimes interventional therapies are the choice for these older patients. Because if you think about it, your alternatives for interventional therapies, oral medications, conservative management like physical therapy, icing, etc., and then surgery. So an older patient, say a 90-year-old patient, you have to have a really convincing reason to give them surgery, such as a hip fracture that you need to fix so that the patient doesn't get all the problems from being immobilized. That would be an indication for surgery. But for a lot of chronic pain issues, this patient might be harmed more by surgery than helped. Same thing with oral medications. Medications which are completely tolerable by younger patients sometimes have adverse reactions in older patients. Older patients are frequently on other medications or have other comorbidities that will make it more challenging to administer systemic medications that are going to go through all the body systems, etc. So a lot of times being able to do interventional therapies on these patients is very palliative. When I'm functioning at the hospital, the academic center that I'm on staff at, I do a lot of interventional procedures that are meant to be palliative, meaning they just are pain relieving. In some cases, even at the cost of like intentionally damaging a nerve, etc. So there is no age cutoff for these procedures. It's your judgment, and if this is the best of all options for the patient.